radiation, benign intracranial meningiomas are one of the very common brain tumors that we have. Meningiomas can occur in intracranial or spinal compartment. Most occur in intracranial compartment, and this accounts for about 90% of benign intracranial meningiomas. We know that the incidence of these tumors is about 25 to 35% of all primary intracranial tumors. These relatively benign tumors in most patients, about 90% of patients with meningiomas are benign. And these tumors arise from arachnoid cap cells, which are cells that are found within the web-like, spider web-like membranes that covers the brain. And these tumors, when they grow gradually and can exist in a patient for years before they become manifest. In fact, they get to a large size by the time they present to the hospital. What are the risk factors? Yes, we know that blacks tend to have a higher incidence of this type of tumors, and these have been noted in Americans, where you have the higher rates of this tumor in African Americans. Likewise, gender predilection. It is more common in females and increases with age. Hence, you have them less common in patients that are less than 40 years of age. A major risk factor is radiation. When they are high dose, with a short latency period, patients can develop meningioma. Low dose irradiation also has been found to be associated with this tumor. From studies done in Israel, we have patients who had tinea capitis treated with low dose radiation now develop multiple meningiomas decades after they were irradiated. Genetic malformation also have been noted with this type of tumors. Specifically, most common, that is NF2, where you have mutation or deletion of the gene at chromosome 22q12 in patients that have meningiomas. Other genetic malformations have been noted in this type of tumors. Also, these tumors, they have been found to have expression of some progesterone and androgens and also estrogen receptors in these tumors. Where are they usually located? Most are convexity meningiomas, accounting for over 20% of meningiomas. But we can have them virtually anywhere within the intracranial compartment, from anterior to posterior, from the intraorbital compartment, anterior cranial fossa, middle cranial fossa, posterior cranial fossa. Sometimes these tumors can be found intraventricularly, and they can account for the presentation of hydrocephalus. How the patient presents? The presentation of these particular tumors will depend on the size of the tumor and also on the location. And the mechanism of symptomatology has to do with their ability to compress either the brain, the vessels, or the nerves. And also, they can irritate the underlying brain tissue, leading to seizures. And these tumors sometimes can invade surrounding tissues and produce hypostosis, either endostosis or exostosis. Hence, what are the various symptomatology? They can range from headaches till various memory loss, seizures, vision that is blurred, or even double vision. And some of them, if they are near the nerves that is involved with hearing, patients can present with a hearing loss. How do we investigate patients with this kind of lesions? We call them neuroimages. Magnetic resonance imaging or a computerized tomography scan are usually done. And at times you add an angiography to these tumors. What we have noticed is that, as I said, these tumors can occur in many parts of the body. So what are the various clinical pathologic features when you do your neuroimaging? One of the major things that you can find is what we call the sunburst appearance in patients with meningioma. When you see a sunburst appearance on a neuroimage, you know that most likely this tumor is a meningioma, and they can grow very large. So by the time they are presenting, you have very huge, humongous tumors for presentation. How do we treat these particular diseases? The goal of treatment most of the time is what we call maximal safe resection. You want to be able to remove everything even though at times there are conditions that will predispose to ability to be able to remove this tumor. So some of them is where the tumor is located. Tumors that are located in areas that are inaccessible, relatively inaccessible, we sometimes go for subtotal resection. If the brain is invaded, then you have at a crossroad to how much brain do you want to remove in the rest of the tumor because of the risk of damage to the brain. And also the patient's pre-morbid status. Those that are not really fit for surgery or their clinical condition precludes surgery, then you'll not be able to resect all these tumors. So but the issue is this: we always go for total resection, because if you're able to remove the tumor, total resection will lead to cure of this patient. So this is one of the tumors that we are always eager. We hope that people will have, because if people have to have a tumor, because when you remove everything, the chances of total cure is there, and that is why the risk of recurrence may still be there based on the molecular profiling of the tumor. When these tumors are removed, we usually send them for histopathology, which will include molecular profiling, because the grade of the tumor determines the recurrence rate of these particular tumors. So those that are benign, which are grade 1, they tend to do very well, but the prognosis decreases as the grade goes higher. Other treatment modalities will include radiation therapy, chemotherapy, immunotherapy, palliative, and at times you don't do anything. You actually watch these tumors, especially when they are small, to see whether they are going to get bigger